Good afternoon, everyone. I'm here with Dr. Jim Doukis, who is the president of Thrombosis Canada, and also one of the co-authors on the recent guidance document, which was published by the International Society on Thrombosis and Hemostasis about diagnosis, prevention, and treatment of venous thromboembolism in hospitalized patients with COVID-19. Now, that's a mouthful, but what we're really hoping to do today is to ask Dr. Doukis some questions about why these guidelines were developed, why they were thought to be important to be produced rapidly by this organization, and also what we can learn from them, how we can apply this to our own patients that we see in hospital. So I'll start off maybe by asking Dr. Doukis, what was the impetus behind the production of this guidance document, which was really put together by a group of experts for the ISTH in a really short period of time?
Thanks, Dr. Siegel, and hello, everyone. It's my pleasure to talk to you a little bit about these clinical guidance statements. The ISTH, as Deborah mentioned, is an international society focusing on patients that have problems with thrombosis and hemostasis. And they typically put out what we refer to as guidance statements. And guidance statements are meant to address common and important clinical problems where there may not be robust evidence from well-designed randomized trials. And of course, thrombosis and COVID-19 clearly falls into that category. We felt that there was an important need to provide frontline clinicians with expert guidance on how to diagnose, how to prevent, and how to treat venous thrombosis in patients with COVID-19, which I think by now we all know is a lot more common than in other clinical situations. So the guidance statement was derived in a very practical way to address common clinical scenarios faced by those clinicians dealing with these patients. And of course, we're awaiting the results of well-designed randomized trials, which still may take at least 2 or 3 months or longer to be completed.
Thank you for that background. Certainly, this is something that is timely and needed, particularly in the absence of good evidence about what to do for patients. So maybe the first question I'll ask is what the committee recommended about the use of thromboprophylaxis or preventative strategies for patients who are hospitalized with COVID-19, but who are not in ICU, so not critically ill hospitalized patients, for example, in a hospital ward. What should clinicians do for those patients?
The first thing, Deborah, is that we looked at this as we would any kind of hospitalized population in whom we are considering that they are at increased risk for thrombosis. And of course, we're not going to uniformly administer thromboprophylaxis with an anticoagulant, and we want to have a measured approach to be cautious, especially in patients at risk for bleeding, whether it's because of recent bleeding, thrombocytopenia, or deteriorating renal function. So with that background, we felt that thromboprophylaxis should be routinely considered with a standard dose heparin regimen, whether unfractionated or preferably a low molecular weight heparin in all patients that were admitted to a hospital ward with COVID-19 illness. And that should be sort of the default management, and patients should receive this in the absence of any of those conditions where we would be concerned about a risk for bleeding. Now, having said that, there was a third of the respondents within the committee who felt that not just give a standard dose of heparin, but to actually increase the dose by 50%. To what we refer to as an intermediate dose low molecular heparin regimen. But as noted, that was in the minority.
Okay, thank you for that, those recommendations for hospitalized patients. Maybe we'll switch gears and ask about the scenario of a patient who perhaps deteriorates on the ward and requires admission to an intensive care unit for advanced life support measures. So these patients are critically ill. What is recommended for preventing venous thromboembolism in those patients? How is this different than the hospitalized patients we just talked about before?
Well, first of all, this is the group of patients where we have the most amount of information from based on the emerging literature. And we know that rates of thrombosis in these patients can be anywhere between 25 and 40%. That's quite high. And even if we compare them to other critically ill populations where the rates of thrombosis are more along the lines of 5 to 10%. Now, again, these data may be a bit exaggerated because they are not from well-designed study, but there's general consensus that COVID-19 is a hypercoagulable disease, and patients, as you just described, Deborah, who are in a critically ill setting are at highest risk for thrombosis. So it's not surprising then that the consensus recommendation was at least standard dose unfractionated or low molecular heparin, but more the needle towards an intermediate dose low molecular heparin. So at least 50% of the respondents recommended that as sort of the initial prophylaxis strategy. About 60% of the respondents actually recommended a multimodal prophylaxis strategy, which combined an anticoagulant with a mechanical method, whether it's intermittent pneumatic compression or graduated compression stockings. Now, where the group fell short is to not recommend a treatment dose of anticoagulation for primary prevention. Now, that may sound really extreme, and in fact it is, but there are some clinicians that have actually administered what we call therapeutic dose heparin to patients without any clinical evidence of thrombosis in this sort of high-risk critically ill setting. So it just shows you the concern overall that clinicians have about thrombosis. But really the message to clinicians is use at least a standard dose of heparin for prophylaxis, maybe combine it with a mechanical method of prophylaxis, or alternatively, you can go to an intermediate dose of prophylaxis with a low molecular heparin, where you increase the dose by 50%.
Thank you. One of the other common scenarios that clinicians have questions about is how long to continue the prophylaxis strategies for. So, for example, patient is recovering while they're in hospital or has been discharged from the ICU and are ready to go home. What is the duration of treatment that is recommended for hospitalized patients with COVID? Should they be treated? Is the guideline recommending additional treatment or extended treatment after patients are discharged?
That's a very good question, because there's been a lot of interest and perhaps some controversy about extended duration prophylaxis in non-COVID patients. Should they receive it after discharge from hospital? And in the average sort of general medical population, guidelines have suggested against giving prophylaxis beyond the period of hospitalization. Now, with COVID-19, that's of course very different. Many patients with severe enough illness that they need hospitalization or are cared for in a critical care or ICU setting often are in hospital for a week, 2 weeks, even longer. So many of them already fulfill the criteria for receiving extended duration prophylaxis. So the question is, what about the patient that comes in to the ward, does not need mechanical ventilation or need to be in an ICU, and they have an average length of stay of 5 days, which is typical for most medical patients? And here the consensus was kind of split, that at least half of the experts felt that about a 14-day period of prophylaxis in total would be reasonable. This is sort of to acknowledge the, again, increased risk of thrombosis in COVID-19 patients, whereas only about 1/5 of respondents wanted to extend this prophylaxis to up to a month. So I think the message here is that these are unusual patients. we don't want to follow the typical guideline, and that it is reasonable to administer a longer duration, at least 40 days. If they're in the hospital for that long or even longer, then that can be perhaps extended to up to 30 days. But generally speaking, there was more comfort at the 14-day duration of prophylaxis.
So, of course, one of the other important questions here that's identified by this group and that is addressed in the guidance document is what the treatment recommendations are for patients who experience a venous thromboembolic event if they have a diagnosis of COVID. What did the guidelines tell us about that situation?
Certainly, I mean, this also ties in the issue of diagnosis of VTE in these patients. And of course, it's hampered because we want to limit patients' contact with other healthcare providers or other departments where X-rays are being conducted. So I think the guideline there, first of all, recommended that we follow standard diagnostic testing procedures, but in some cases we may want to rely on indirect methods of diagnosis. For example, using an ultrasound of the lower extremities or a point-of-care echocardiogram to indirectly diagnose pulmonary embolism as opposed to sending that patient to have a CT pulmonary angiogram. So when a situation arises where VTE has been diagnosed or is highly suspected, the guideline group recommended in favor of adhering to current standards of treatment for established VTE, whether that is with a intravenous fractionated heparin or a low molecular weight heparin. There was some reticence to favor the use of a direct oral anticoagulant, in part because of concerns of potential drug-drug interactions with other treatments that are currently being investigated or administered for COVID-19 pneumonia. And as well, the duration of treatment was thought to be as per a usual episode of venous thrombosis of at least 3 months. These would all, of course, be considered secondary or provoked episodes of VTE. And then the final point is, I think really important for clinicians, is that half of the respondents felt that it was important to actually administer a therapeutic anticoagulant regimen, even without diagnostic confirmation, if there was clinical suspicion. For example, ventilatory requirements are increasing or oxygenation requirements are increasing without any clear alternative reason. And finally, the point about should the anticoagulant regimen be adjusted based on D-dimer levels. Now, we know COVID-19 patients have high, in some cases very high D-dimer levels, and we know that it is a predictor of poor overall prognosis and increased mortality. But there is no correlation, at least to date, with D-dimer levels and the presence of thrombosis. In most cases, it acts as an acute phase reactant. So the committee felt that you should not rely on D-dimer levels alone, but more clinical factors if you want to administer therapeutic dose or treatment dose heparins in these patients.
Thank you for that explanation. I think that these guidelines will be very helpful for practicing clinicians. I mean, really, we've talked about a few very important issues related to thrombosis in COVID-19 patients, prophylaxis in hospitalized patients, prophylaxis in ICU patients, diagnostic strategies and some of the challenges around that in COVID-19 patients, and then also some treatment considerations. Again, this was a guideline or guidance document that was produced with experts from around the world, and will provide some helpful information for physicians in order to manage their own patients. So thank you for that. I don't know if there was anything else you wanted to talk about the guidelines or any other important messages that you'd like to convey to people who are watching?
Yeah, thanks, Deb. I think the only other message, and I think folks that were listening to this would have surmised this already, is that the purpose of this guidance document was not to forge a consensus and sort of force that consensus, because as we all know, the evidence here is emerging, and as I mentioned earlier, we're awaiting the results of high quality randomized trials to inform best practice. But I think it was equally important to identify where there appears to be some consensus as much as where there isn't consensus. So clinicians dealing with this real problem aren't sort of compelled to follow a certain direction, and it will provide them with some reassurance that even, you know, the so-called experts are not sure about the best management. But overall, I think the reasoning for this was to meet this need where this is a real problem, it's a common problem, and we need to have some guidance. So hopefully some of the issues will be addressed through this. And once again, you know, this will be updated, of course, once we have the findings of the randomized trials dealing with these specific questions that you've outlined, Deb.
Okay, thanks so much for taking the time to introduce us to these guidance document, and we look forward to speaking with you in upcoming episodes.
It's my pleasure. Thank you very much.
Okay, we also look forward to randomized trial data.